Hey, hello everybody, and welcome. I'm Mark Levine, City Council member. I want to thank you for joining us on a very difficult day for our city, for our country. I just want to check whether our very special guest, Dr. Uché Blackstock, has joined us yet. I believe she's on.
Yeah, I'm here. I can see you.
Wonderful. Welcome, Dr. Blackstock.
Thank you.
We're
Thank
so
you for
honored to
having
have
me.
you. Oh, it's a pleasure. And of course, I'm Mark Levine, City Council member from Northern Manhattan and chair of the Health Committee. And this is another of our ongoing conversations with the leaders who are confronting the coronavirus pandemic. And I'm thrilled today to speak to someone who is not only a leader in the field of healthcare, but also in the field of racial justice as we confront not only a medical crisis in our city and country, an economic crisis, but also a crisis of justice as we mourn the murder of George Floyd and countless other African Americans who have died at the hands of police, and, and a time in which we are anguished and angry and demanding solutions and actions. And we scheduled this conversation with Dr. Blackstock before the events last week. But we're going to have a lot to say about that and its deep connections to the coronavirus pandemic and to the racial inequality in healthcare more broadly. So I do want to welcome you again, Dr. Blackstock. And I want to invite folks to put their questions in the Zoom. We know many of you are following us on Facebook. You can put your questions on Facebook too, and I'll make it to us. Just going to say a word briefly in Spanish. Bienvenidos de nuevo a otra de esta serie de charlas con los líderes que están enfrentando a la pandemia de coronavirus. Ustedes pueden hacer sus preguntas en el idioma que desean. Pueden hacer sus preguntas tanto en Zoom como Facebook. Y aquí con nosotros la doctora Uché Blackstock. So Dr. Blackstock, we're so honored to have you. You are an experienced ER doctor. You are a professor of academic medicine. And in the last 6 months or so, you embarked on an important new project focusing directly on equity in healthcare. You also have a very famous sister who some of those joining us today might know. Yes, twin, identical twin, Dr. Uché Blackstock, who is an assistant commissioner at our city's Department of Health, and who I've also had the pleasure of working with. So perhaps, Dr. Blackstock, you can tell us a bit of your story and how you wound up as an emergency medicine doctor and in academia, and your current focus on equity in healthcare, please.
Sure, I'm happy to, and thank you so much for having me, and thank you for your very thoughtful and profound words about our current moment. I'm hoping that we can come in fellowship and community this evening and talk about potential solutions. I think that when we're in crisis, it's an opportunity to talk about change and be innovative. And so I'm hoping that we can do that together this evening. So, hello everyone, I'm Uché Blackstock. I'm actually born and bred in Brooklyn, New York. It's my favorite city in the world, but it's obvious, given that my sister is also doing justice work in her own way, working for the health department, that our parents have obviously instilled in us a great sense of service and obligation to our communities. And so I would say that I'm also a second generation physician, which is also very interesting. Our mother, who was the original Dr. Dale Blackstock, was born and raised in Brooklyn as well. And she was the first person in her family to go to college. She went to Brooklyn College, was pre-med there, and had a professor there that encouraged her to apply to medical school, which she did. She hadn't even thought about it, got into all of her medical schools, ended up attending Harvard Medical School, was in culture shock there because she was someone who had grown up in poverty. She was the daughter of a single mom with 5 siblings. They grew up on public assistance. in Crown Heights, Brooklyn, and she was in this new environment. Anyway, our mom came back to New York City, trained at Harlem Hospital, and came back to Brooklyn and worked at Kings County Hospital in the same community in which she was raised. And so obviously that's where we get a lot of our values from. And so, I also trained in emergency medicine at Kings County, and I was at NYU School of Medicine for almost 10 years, doing diversity work and working in the emergency department. And it really became apparent to me, especially doing my diversity work, because what we know is regarding racial disparities, that in order to close the gap in racial disparities, we also need to address workforce diversity, because we have sufficient data that shows we have an increased workforce diversity, more Black, Latinx, Native American physicians. That's one factor to helping to close the disparities. So I actually started my organization advancing health equity for that reason, but it's actually turned into something so much more, and I'm providing consulting services to healthcare organizations, not just around workforce diversity, but how they can better treat their diverse patient populations and achieve their health equity goals. So some services that I offer are like unconscious bias trainings, racial equity trainings, and sort of similar talks and trainings like that. And so I've been able to really work with organizations around the issues that we're seeing now in the COVID-19 pandemic. Right now, I still work part-time. I work part-time in urgent care. So I do 2 or 3 shifts a week. And so I've been on the front line, so to speak, seeing patients with COVID-19. And we can talk a little bit more about my observations and the work that I've been doing.
Well, I'm looking forward to that discussion. You and I have spoken about the connections between the racism that is driving the current epidemic of police violence against Black Americans and other people of color, and the profound inequality of the coronavirus pandemic, which is afflicting Black Americans and communities of color, and specifically in New York City. The fatality rate, as you know, for African Americans is double that of whites, and for Latinx workers, it's comparable as well. What are the common links, the threads that join these 2 different crises that may have a very similar root?
Right. No, it's such a great question. And, I think often we think about racism as something that's just interpersonal between 2 people. And so this idea of structural racism, I think it's very important for people to understand how there can be practices and policies that give advantages to one group over the other. So let me give an example. So I'm sure some of the folks in the audience have heard of redlining. Redlining was a policy, a federal policy, in fact, in the 1930s that essentially graded neighborhoods from A through D. And a lot of the grading ended up being based on who was living in those neighborhoods. And so if a neighborhood got a D rating, that neighborhood, those who lived in those neighborhoods were less likely to be able to qualify for federally backed mortgages and mortgage insurances. If you got an A, you were more likely to qualify. What ended up happening was those neighborhoods that were mostly Black, people living there were not able to get mortgages. And so what that led to were decades of disinvestment in those communities, because when you're not able to own your home, right, property values don't increase, businesses don't want to come to live there. Remember that property taxes go towards education, schooling as well. So the schooling suffers as well. And so what's interesting is that you say, okay, sure, that happened in the 1930s. But what we can see now in cities, actually, not just New York City, but in cities across the country, is when you put that redlining map on neighborhoods that had D ratings over areas that have the shortest life expectancy, highest asthma rates, highest rates of obesity and diabetes and high blood pressure, those are the same areas that got those D ratings back in the 1930s. And so it's really important to understand how legislation and practices and policies can end up impacting health, education, different aspects of the way that we work and live, decades down the line. So that's just sort of one example.
Every one of the underlying conditions which make someone vulnerable to coronavirus, you can tie back to specific policies. Access to healthy food, for example. We know there are food deserts in neighborhoods of the city and beyond where healthy food is either not accessible or not affordable, to give one example. Access to primary care and preventative care. And there's still too many people in the city who aren't getting annual physicals and the preventive medicine that it takes to remain healthy. And so often they don't get health care until they're in crisis and in an emergency room. And against that backdrop, those folks are going to be more vulnerable to a virus like the coronavirus. So it's tragic that it's come to this, but I think you probably were not surprised because you've been following this for so long.
Exactly. It's interesting. Towards, I think in mid-March, I started seeing in my practice a change in the patient population. So I work at several urgent care sites throughout central Brooklyn, and the patient populations are typically racially, socioeconomically diverse. But as soon as COVID hit New York City, the transition was very apparent. Started seeing mostly Black and Latinx patients, primarily. Many of them, because I really like to talk to my patients and engage them. Many of them were essential workers. They work for the MTA or Postal Service. So they were people who could not stay home. They also were service workers. Some were food delivery folks. And so they were still essentially on their own front lines, so to speak. And they were exposed. And so I started making these observations, and this was even before the demographic data came out, the racial and ethnic demographic data came out for New York City, that I saw this shift in who I was caring for. But it really made a lot of sense, not only in terms of what kind of jobs these patients had, but also in terms of the comorbidities that you mentioned, that it turns out that diabetes, high blood pressure, and asthma are underlying factors that make people do very poorly when they contract coronavirus. And then also you're talking about access to care. One thing I also noticed, obviously is the issue of testing. There was limited testing availability even to begin with, right? So we know that to be a fact. And so, even with the CDC initially, their testing criteria was dictating only that people who had traveled to an area that was endemic, so China or Italy or Iran, or had to know someone who had been tested, only those people would be eligible for testing. And the fact is that most of the Black and Latinx patients who were essential workers and service workers who were coming to my urgent care, they had not been to China, Italy, or Iran. They also didn't know anyone who had been tested because at that point, testing was so limited, and people that we knew had been tested were mostly celebrities, politicians, or folks, from affluent populations who could contact a company privately to be tested. And so I thought about how early on there was even bias embedded in the testing criteria for who was being tested. And I did worry about how many patients did we miss because the testing criteria was so narrow.
We missed a lot, clearly. And there's no doubt that wealthier folks found a way to test.
Right.
They found a way.
Absolutely.
And so testing rates were actually higher in upper income neighborhoods of New York City, even though the actual incidence of coronavirus was lower, which skewed our view also because we weren't registering many patients in communities of color, even potentially at time of death.
Right.
And, go ahead, please.
No. So basically, we are probably undercounting, right? How many
Indeed.
people have died because of that. Yeah. And other things that, no, go ahead.
Well, New York City did make one change that a lot of us organized for, which is they've now started to count people who, though they didn't have a positive test at time of death, the physician or the medical examiner said is a probable case. Even that's probably still an undercount,
right?
But it's gotten us closer. By the way, Donald Trump, when we did that, said we were faking the numbers, which was obscene. The truth is, it was just getting a more accurate count.
Right,
Every one of those
right.
cases is reviewed by either a doctor or the city's medical examiner. But please continue.
No, I was thinking about, you know, how typically, about 20 people a day die at home in New York City, but towards the apex, I think it was like 200 a day. And one thing that registered to me as I was taking care of my patients was that a lot of them had a distrust of the healthcare system, and a lot of them were wanting to stay home for as long as possible because they were worried that if they went into the hospital, that they would not receive adequate care. And so I'm thinking a lot of those people who died at home were probably the similar perception of healthcare, which is totally valid because you have this history, right, of Black communities, interacting with the healthcare system and provider bias. And so that's real as well. And I even had an elderly man in his 60s who kind of was on the fence in terms of whether I was going to send him to the emergency department for my urgent care or whether he was safe to go home. And I was giving him, instructions. I said, please, if this happens, worsening chest tightness or shortness of breath. And he said to me, no, I'm not going to the emergency department. Wow. I'm not going because I'm going to die there. Right. Wow. And so, one thing that I've been thinking about a lot is sort of messaging to Black and Latinx communities has to be different than it is to other communities, right? Because there are a whole other set of issues and history, right, involved in these communities and their relationship to the healthcare system.
Yes, indeed. So we're getting some very good questions coming in, and I'll try and give you a few of them. We have a question from Mika Simonis, who says, as someone about to start residency in internal medicine, what are some ways I can prepare to promote health equity in my new role? And what should I be particularly mindful of during my first year as an intern?
Oh, that's a great question. And congratulations on getting your residency position. And so what's interesting is that I think trainees, so residents and medical students actually have a huge role in advocacy to play, especially around healthcare disparities. You can make sure that it's part of your resident conference, the topics that you talk about in resident conference. You can make sure that it's part of any community engagement activities that you do. So we know, per the social determinants of health that, education, housing, and employment are factors, not just access to healthcare, that influence someone's health status. So getting involved with community-based organizations that are also doing that work as well. So amplifying the message around health inequities is important. You can do that as a resident. And then also, I think we often forget about really becoming engaged with our communities and really finding out what our communities need. I think we can make a lot of assumptions. It's not until we speak to community members in faith-based organizations or neighborhood coalitions about what those needs are.
We have a question from someone who seems like they may already be working in healthcare. They came in as anonymous, but it says, as healthcare professionals, how can we support these in-person protests while not supporting the lack of social distancing, fearing more death in our communities, or is that not our place?
No, of course it's our place. Yeah, no, we are, we want justice, right? We want justice for the most vulnerable people, the people who are being disproportionately impacted. And so the two are not mutually exclusive as well. In fact, I think part of the role of being a healthcare professional is that we advocate for human rights for all, and part of that is also racial justice. And so, we know that it's impossible to have no risk situations with coronavirus, right? And so, there are some guidelines that actually the Department of Health came out with around protesting, and definitely you're going to wear your mask. You're going to you can stay with your, try to stay with your small group of people that you're with. Try to, obviously socially distance as much as you can, bringing hand sanitizer. Also, bringing protective eyewear, because pepper spray can actually, make the eyes very watery, and you can sneeze, and that can increase transmission of the virus as well. And so, so sort of just using all of your, all of these sort of precautions to reduce your risk as low as possible. But, definitely the two are not mutually exclusive. I think it's our responsibility to get out there.
Absolutely. Last week we had a wonderful guest, Dr. Julie Marcus, who's an epidemiologist.
Oh, yes. So
Yes.
she talked to all this. That's the expert.
Exactly. Well, she spoke about the harm reduction approach.
Right.
Which is to say, in the real world, people are going to have some social interactions.
Right.
Let's help them understand the risk and how to minimize it. And that's exactly what you did right there vis-a-vis protests. How ironic is it that police, when they use tear gas, are forcing people to rub their eyes, which is something that spreads coronavirus, or forcing them to cough,
right,
which
right,
also spreads the virus.
right.
It's a violation of public health principles. And if people are then put into jail cell,
Together.
that, as you know, a major setting in which the virus is spreading
Right.
rapidly.
Well, I was even thinking about how, we had that data from a few weeks ago on how people who were arrested for social distancing violations were disproportionately Black and Latino, and that some people were being put in jail. And so it's like, that is ridiculous. So you're basically penalizing someone for not obeying social distancing policies, but then you're putting them in jail and you increase the risk of them getting coronavirus. Like, it just doesn't really make any sense. Yeah.
Absolutely outrageous. So we have a question from Kevin Lee, who says, you raise a very important point about the lack of trust that underserved communities have towards the healthcare system. How can we act to win that trust and increase access to quality care?
Yeah, no, again, that's a great question. And so I'm all about community engagement and community partnerships. So I think every healthcare institution should have like an office where you are working with the community that you serve, and that you have community liaisons that are working with you. I think also there is a role for community health workers. I think we haven't talked about them enough in this pandemic, but they are they're professionals. They're lay people who usually are either from the community or familiar with the community that they're working in, and are considered trusted individuals, and that they can go out to education, outreach. They can even do contact tracing as well, and so these are people that I think are important to really have on the ground. They can do door-to-door assessments, but it's really important that we sort of get out of our healthcare institutions, out of our hospitals, out of our clinics, and really form connections with churches, schools, community colleges, whatever it is. We really need to get on the ground to understand what neighborhoods need, and I think that will help. But I will say that, and I think on the other side of it is working with hospitals around talking about provider bias, because the fact is that we know, and there's a lot of data on this, that clinicians overall have an implicit preference for white patients over patients of color, right? And I think everyone would say, I'm going into healthcare, I want to help everyone. But the fact is, and we know this because we have data that shows this, that everyone is not treated the same, right? We know this regarding how people's pain is treated. We know that Black people's pain is consistently undertreated. And we have a lot of pain literature about that. And so, I think that we really need to be talking to healthcare professionals also about this, and making sure that we're, it's not just about trainings, right? And I do trainings, but one and done is not enough. It has to be a part of the conversation always.
No, it's analogous to a problem which we have in law enforcement, which is sometimes called implicit bias, but it's happening in healthcare as well. I don't think that's been covered as much,
right?
But it's now impacting the pandemic currently.
Right, exactly. No. So you don't think it's been covered in policing or healthcare? Healthcare?
Well, healthcare, I don't think it's gotten as much attention. It's a long-standing problem.
Yeah. I
the
mean, but
bias in medical institutions.
yeah, absolutely. I mean, I think it's unfortunately it's like even though like I think probably Black patients could say I get a sense this is happening, it's not until you actually have hard data. This is how the society works that show it, and then you have to act on it. But I think it's getting discussed more and more. And one point I did want to make is that I think that implicit bias in itself, the term, people think of it as very benign, like, oh, I'm unaware of it, so it doesn't really matter. But the fact is that it has as severe and profound consequences on health and health outcomes as like explicit bias. And so it's something that has to be addressed.
We have a question from Michelle Alexander. I don't know if it's the Michelle Alexander, famous author, but she says, I knew your mom, Dale. We worked together and were in Susan Smith Stewart McKinney Medical Society. Can you focus on some recommendations regarding disparities related to food and environment and the development of disease?
Oh, first of all, thank you so much for mentioning my mom. You try to make me cry on here because our mom passed away when we were in college, and so yeah, so it's always nice to hear her name.
Oh, so sorry.
Thank you. So I think that in terms of food access, and we talked about these food deserts is a huge issue, definitely tied to redlining. And I think that even in this moment now, when we're thinking about how do we support communities that are being disproportionately impacted, one thing is making sure that we're providing social services regarding funding food banks and making sure food banks have adequate amount of food. But then also, making sure that we're connecting community members to those food banks, and whether it's, delivering meals door to door to elderly people who can't get out. But we definitely have the resources there. The only problem is that we just don't have, enough funding to make it more robust. And what we do know is that, even though these communities have higher rates of diabetes, high blood pressure, and obesity, that this is a direct result of access, right, and history. So even back in slavery, slaves were given basically the scraps to eat and were restricted from access to healthier foods. And so we actually see even some of that today in terms of how access to foods, and depending on what neighborhood you're in. And so the redlining and the food deserts, even that overlays each other. And so basically, structurally, we need to address those issues structurally, essentially is what I'm saying.
Absolutely. And the food banks are more important now than ever as so many people are living without income. We see it in Northern Manhattan. The demand is off the charts. They're all underfunded. All the food banks are struggling themselves. I have to say, though, we have to make sure that we are serving healthy food in food banks.
Right.
Bologna sandwich in a bag of chips is not healthy.
Yeah.
And it's actually more work, but we need to distribute fresh produce,
right,
not only canned products, because of the health benefits. Otherwise, we're reinforcing some of the inequalities of
right,
access
right,
to healthy diet. That costs money, and we're underfunding food banks right now. That's going to have to be a huge priority, though, because
right. It has
we're
to
just
be,
seeing the demand is just so great now. We have a question from Martin Wallace. My grandfather was a doctor at a time when doctors were still made house calls. Is there a strategy that could improve health outcomes in poor neighborhoods? And if so, is this a strategy that could improve outcomes in poor neighborhoods? And how could we make this happen?
No, that's a great question. And there actually are like home visit programs. There's actually across the country, they're on a smaller scale, but even there is an organization called City Block. I don't know, Mark, if you're familiar with it, but they basically, they may not be physicians, and that's the other thing. So I think it's great when physicians can, go out, but physicians aren't the only people in a care team. There are, there are nurses, there are physician assistants, there are social workers, community health workers. And so, this model where you have sort of a team-based approach where, you can have people going into the home, and especially for people who are homebound, is ideal. And we have a lot of really great data that shows that that does improve disease outcomes and chronic disease management. We just need to, really expand those programs more. It actually got me thinking about,
Especially
like,
now.
yeah, right. No, go
Please,
ahead.
please.
No, I started thinking about telehealth and how sometimes, people are seeing telehealth as like a panacea, but it's really not all, for all populations. It's great in some ways, but it definitely has its limitations in terms of, especially some services are text-based. So you're text messaging with your doctor. And so depending on, culture, education level, that may not be the ideal way to communicate.
Yes, not to mention internet access or having a device at home, etc. And I mean, this telehealth has gotten more use during the last 2 or 3 months than any time in history. But again, it's in some ways reinforced inequality because of who has access to all the infrastructure.
Exactly. Or broadband, right.
Yeah, exactly. There have been, there's some good pilots happening right now in NYCHA, where we do have some door-to-door in about a dozen developments. It's actually not a doctor, as you mentioned. It's someone who has access to a doctor on an iPad, and they can take a blood sample, blood pressure test. They can deliver a vaccine on the spot. This is so critical to people who are homebound and haven't been getting annual physicals. And when I think about what it means for a city of 8 million people that there's been no preventive care for 2 or 3 months, I mean, that's a very serious threat.
Yeah, I know that some of the Department of Health equity initiatives, the Center for Health Equity, I think some of the approaches they were taking was contacting doctors' offices in these neighborhoods and actually going into the medical records and seeing which are the patients with the most profound health problems, and really reaching out to them, whether it's in person or by phone, to see how they're doing, to see what their needs are. But that is like, that was the it's the second wave, so to speak, and that I think that we are seeing or starting to see of patients whose chronic diseases have not been adequately managed because they haven't been able to seek care during that time.
Absolutely. So we have a question from Terry Wisdom from Harlem Network News. She says, where are we with COVID data and reopening, as the virus has now taken a back seat to the demonstrations and protests of the deaths of innocent Black people and the support of Black Lives Matter?
That's a great question, but I feel like you
yeah.
probably know more than I do, right? I thought we reached like 5 out of 7 of the metrics, right?
We have been, yes, we are scheduled to reopen on Monday, a week from today. Phase 1 reopening. We are going to reopen manufacturing, construction, wholesale. The one that will affect most regular New Yorkers is retail is going to be open, but only for curbside delivery or in-store pickup. So it's a step in the right direction. And actually today, ahead of time, dentists have been allowed to reopen. So we're moving in the right direction. But, as for the data, we're not out of the woods yet. We still have about 4,000 new confirmed cases a week in New York City, a lot less than it was, but the virus is still out there. And as the weather gets warmer and people start to get out into public more, boy, we have to be real careful about this. And you mentioned the metrics that we need that the governor had laid out to open. Well, one of them is contact tracing.
Right.
And this is something that we should probably take a minute to talk about, because this actually started today in New York City. And it's a program that has a goal of talking to everyone who tests positive for coronavirus and checking who they might have exposed, someone they live with, someone they work with, and then reaching out to those individuals so that everyone who is infected or potentially infected, whether they have gotten a positive test result or just are suspectful that they might because of exposure, that they should be home quarantining, or if that's not possible, isolating in a hotel. This is a tried and true strategy, which folks like your sister at the health department have been implementing for many other infectious diseases, from HIV to measles to hepatitis. Um, so we know it works, but it's going to be a big deal for New York City, especially at a time when there's great suspicion of government. There's fear of sharing data if you are an immigrant, undocumented.
Yes.
I'm really worried that this is going to be seen as another unfair and over aggressive enforcement measure, like home arrest or something.
Right.
That quarantine could be seen that way. How can we, Dr. Blackstock, how can we make sure that this program is embraced
Right.
by communities?
Yeah, I've been thinking about this a lot, because even you have to not only quarantine yourself, but you have to tell someone that you don't know, who you've been in touch with, who you've been in contact with for more than 15 minutes over a certain period of time. That's personal information, right? Yeah. And that was one reason why I was talking about maybe, you know, having community health workers, or that kind of model where you have people who are from the community or know the community well, as contact tracers. I think that is really important, because otherwise you're going, that distrust that we talked about between healthcare institutions and Black and Latinx communities is just going to rear its ugly head again. And it's reasonable. I mean, other thing I was thinking about was also the protests. I think there was some concern about protests and street closures interfering with contact tracing if someone has to, like, you know, travel. Maybe you would know more about this. Is the contact tracing just done by phone, or do the contact tracers actually have to be on the ground?
Well, if you answer the phone, then the interview can be done that way. But if you don't answer the phone, they will go to your door.
Yeah, right.
And that's a very sensitive interaction. Someone's
Yeah.
going to show up with a bunch of PPE, and I mean, who the heck knows how people are going to react to that. And I think that you have talked about, in general, I think in healthcare, engaging with neighborhood organizations, local leaders, people who have the trust of the community, who speak the languages of the community, who have cultural awareness. And I don't think there's ever been a health program which more demanded that
Absolutely.
than contact tracing.
Yes, absolutely. Absolutely agree. It's going to
And,
be critical. It's going to be critical to the success of the program, and especially if we're targeting certain communities, even more so.
and disproportionately, it is affecting communities of color, and that's where we have to focus those resources.
Yeah.
And we need an awareness campaign, education. Everyone's talking about the census now, thank goodness, and you have to fill it out to get resources and political power. That in part happened because we have spent in New York City tens of millions of dollars on funding CVOs, community-based groups, to help get the word out. And I think every community meeting I go to now they're on Zoom, but at least someone in that meeting, one person is going to mention you have to fill out the census. Thank goodness.
Right.
We need that investment
for contact tracing.
Absolutely.
No, it's so interesting, because the testing and tracing and test, trace, isolate, like it sounds so simple, even though it's more complex, but it's incredibly effective. I mean, we saw what self-isolating or shelter in place did since March. I mean, I even witnessed it in my clinics. Like, we were all of a sudden the COVID cases exploded, and then they just went down. And now I see very few new COVID cases. So
that's
this
incredible.
It all works. It's just that everyone has to be on the same page.
So we have a question from
effectively. Yeah. No, go ahead.
We have a question from Maria Castellana, who says, what can we do to protect essential workers that are mostly African American, Latino?
Yeah, no, so it's such a good question. And, like I said, a lot of my patients are essential workers, and, some of them had shared with me some very concerning things that at the beginning of the pandemic, that they were told they couldn't wear PPE or they couldn't wear masks at work because they would scare customers in the subway. And so I'm hoping that we've moved away from that. But what's really essential is that every essential worker and service workers, like grocery store workers, food delivery people, that we have a way of getting PPE to them. And so I also feel like the city should work making sure that we work with employers of businesses that are open to ensure that that all employees have PPE. I think they should also get hazard pay. I think that's a must. We should ensure that they have access to health insurance in case they get sick, and financial assistance. This is a must, and that they have a sick leave as well. I mean that's the minimum. Yeah.
If you're asking someone to quarantine,
Right.
and they have an hourly wage,
Right.
you're asking them to have no income for 2 weeks.
Exactly.
If you telecommute, you don't have that problem.
Right.
I think we need to offer either income replacement or financial incentives if we're going to ask people to quarantine.
Yes, absolutely.
And it's important to say that we don't want this to be a mandatory quarantine that's enforced. We want this to be done through education and incentives.
Yeah. Right.
Otherwise, I think it's going to go in a really bad direction. And we haven't actually seen the quarantine order in New York City yet, which is a little bit worrisome to me. But we better make sure it's not a law and justice quarantine order, that we are focusing on.
Yeah, I was going to ask you about that. What happens if someone tests positive and they refuse to be quarantined?
Right. Well, it depends how the order is written. In past epidemics, we actually would issue a fine. For example, in the measles outbreak of last year, a number of people were given $1,000 fines. I mean, the most famous case in history is Typhoid Mary, who was ultimately imprisoned. But we don't even want to go there in coronavirus. We don't need to go there.
We don't need to.
We need to educate, offer incentives. For example, when you quarantine, you're not supposed to leave the house for anything other than a medical necessity.
Right. So we should make sure that people that we have services to bring them groceries. If they need medical care, whatever that we support them. Prescriptions, exactly.
Even laundry and dog walking. Yeah. You don't want someone hanging out in the laundromat if they are contagious. Let's talk about a confined space. So
I know,
right.
Yeah, no, but the point that you raise about really talking to community members is so important, and educating them about it, and there being a back and forth discussion. So people saying what their concerns are. Because I will say, as someone who cared for patients with COVID-19 and this concern about a second wave, I literally almost started crying the other day because I said, I don't want to see people suffering like that again. Because I had never seen anything like that. I've been practicing for 15 years. And that was an urgent care. Like that was, but the look on those patients that were very sick, the look on their faces, like, I think I'm gonna die. I don't wanna see that ever again. And so I think that it's really about having a nuanced conversation, around messaging and education. And that looks different depending on the community.
Absolutely. I want to clarify that Michelle Alexander has told us that she's actually a medical doctor, internal medicine physician, not the famous author, but famous on this Zoom. So we have a question related to the sensitivities around contact tracing from a good friend and well-known local leader up in Washington Heights, Indiana Porta, who says she's concerned that people might not feel comfortable sharing where they've been out of fear that confidentiality will be breached, out of fear they might be judged for their day-to-day activities. For example, teens might be scared that the information will get back to their parents. This is concern about privacy rights of young people in contact tracing. You can think of so many examples. Someone is in mental health counseling. Maybe they were meeting with their pastor. Right. They go to Alcoholics Anonymous. There's so many private interactions. Do you have thoughts on how we can assure people that their privacy will be protected?
I mean, I think that we have to be very clear about, about how we're going to keep that information safe, right? We need to be able to explain sort of all of the process and the mechanisms in place. And so I think probably the majority of it is going to be just really talking to people who test positive and explaining how the program works, right? And ensuring that we have those mechanisms in place to keep all of that information safe and sound. But I mean, that's totally, those fears are warranted, absolutely.
The fear is real. One thing that we have to clarify to folks, if you test positive and you share your contacts with the tracer, no one will be told your name or identity. So if you say, well, I was in my supermarket where I work, they'll call someone and they'll just say, an individual you were in close contact with has tested positive. They won't say the name or other identifying characteristics. So there's some anonymity. And the city has stated unequivocally that there's no circumstance in which they would share data with immigration authorities or the federal government. And we actually have something of a credible track record on that, because with our municipal ID that many of us have, when some Republicans started to threaten to seize that data, basically we destroyed the database rather than expose it to seizure by some sort of hostile immigration authorities. So but we got to get that message out, because who's going to know that unless we get the word out.
And what's interesting also is that I think these same issues come up with when we're talking about the vaccine, even though that's a long way away, but we have time to think about it. But I have concerns that especially Black community members won't want to take it, because I'm thinking about the Tuskegee experiment, where it was a federally funded study by the U.S. Public Health Service, where men with syphilis, they were known to have syphilis. They were just told they had bad blood. And even once there was a treatment, penicillin, for it, there was a subset of those men who were never treated. And the study went from, I think, 1932 to 1972, over 40 years, right? And a federally funded study. And the only reason that it ended was because an epidemiologist at the CDC broke the story to the AP. And so, we're working against a lot. I mean, I even have close friends and family members who told me I'm not taking a vaccine if it comes out. And so we have to stay ahead of the ball in terms of working with communities around, the messaging around vaccinations.
Oh boy, that's a big challenge and important.
Right, so and we may see a racial disparity with that too. So just to keep in mind.
Right. So I want to ask a sensitive question, but one that I think is important to talk openly about. What message or advice or guidance do you have to white allies or non-Black allies in institutions or movements, whether the arena is healthcare or criminal justice or economic justice?
Thank you for asking that. I had this experience in academic medicine where I felt like I could not talk about racism out loud because I was worried about repercussions, right? And so what really is needed is I would have loved if my white colleagues would have, been a little bit more observant, not a little bit, a lot more observant, and seeing that there were very few Black faculty at my institution. I wish that even if they did notice, that they actually spoke up also. And then also, I wish that they also would be in the trenches doing the work around changing culture, changing policies, and then even on a personal level, really understanding what it means to be an anti-racist. So I know we hear about this a lot, but it's one thing to say that I don't agree with racism, but it's another thing to think about how are you complicit, right, in benefiting from racism, and how are ways that, and that's also going to require giving up some elements of power and privilege, right? But if that happens, we will have a more just society.
Thank you for saying that. It's very powerful and something that we all need to take to heart now, more than ever. We have a number of other questions. I'm going to try and get to as many as we can. We have about 10 minutes left. I have a question from Dawn Gresham. what are some actual policies in New York? She said state, but we can talk about city as
Mhm.
well, that would help increase equitable access to healthcare and decrease racial disparities in health outcomes.
So I mean, one thing is access to insurance status, right? Ensuring that everyone, regardless of their documentation, has access to health insurance. And I'm pretty sure, I think in New York City we have that, right? Or to
Uh,
some degree,
we could do better even in New York City.
right?
We have hundreds of thousands, mostly they're undocumented New Yorkers who lack health insurance. We have a good state program, Child Health Plus, for people who are under 18, even if they're undocumented. But for adults, no. And it's created incredible disparity in health
Right.
access.
Yeah, exactly. Because I mean, the only way that we can get preventive care, because really the ideal is preventive care, right? That's why we want people to have access so that they don't develop these, end stage diabetes, high blood pressure. And so we need to make sure that we have higher insurance rates in Black and Latinx communities. And then I always come back to social determinants of health in terms of like, access to gainful employment with benefits, access to safe housing and adequate housing, and then also access to a quality education.
Exactly. We do have time for, if people want to put a question or two on the Q&A, we're happy to try and take them. I want to look at the future a little bit and ask, what kind of impact do you think the horrors of this pandemic and the parallel crisis in criminal justice will have on the fight for equity in these arenas in the months and years to come?
Yeah, wow. Yeah, no, I mean, I think as I mentioned, I may have alluded to earlier, like this is a time for structural change. And so, I'm actually going to be speaking to on Thursday the U.S. House Select Committee on Coronavirus. They asked me to
Oh
speak
my
for 5
goodness.
minutes. But to have this opportunity to influence legislation is huge, because I feel like that actually is sort of one of the ways that we can address structural racism. But in my statement, which I haven't finished yet, I do want to sort of bring up how these disparities and inequities are deeply rooted historically, right? And so they are going to take a very long time to change. But if we all keep our eye on the prize and the goal of really essentially dismantling this system that's been created based on inequity, that I think we can make some progress. And so what that looks like is equitably allocating resources, right? And so even if it's talking about in real time right now in the pandemic, making sure that we're targeting testing, contact tracing, PPE, adequate healthcare resources to Black and Latinx communities, or whether that's long-term thinking about the social determinants of health, like, access not just to care, but quality care. One thing that we didn't talk about was that often in Black and Latinx neighborhoods, we have what are termed minority serving institutions that have actually traditionally provided poor quality care, and so it's just sort of compounding issues that are already there. So sort of, all of those issues.
And we saw painfully in the last few months incredible inequality between hospitals in New York City, some that are well funded and some that are independent hospitals that are in communities of color and were struggling even before the pandemic.
Right.
Flushing, Jamaica, St. Barnabas in the Bronx, and they serve an overwhelmingly African American and Latinx population.
Right.
And they don't have the same equipment. They don't have the same staffing ratios. They often have buildings which are in desperate need of modernizing or repair. And talk about what impact that must have on health
No,
Uh,
absolutely. Yeah, absolutely. If they're not, and so that's why, like, when some of my patients told me they were scared to go to the hospital, I was like, I understand, because not all hospitals are created equally. There are certain hospitals that don't even have intensive care units, or have enough ventilators, or people trained to know how to use ventilators. And so we have, New York Times did a great piece. I think it was on SUNY downstate and another hospital in the city, just showing how disparate the care was. And not to say the people that are working in those institutions don't care about the patients, they do, but they're working with very, very limited resources. So we really have to think about ways that we can focus on equitable allocation of resources, because right now it's profoundly inequitable.
we've talked mostly about physical health, but also mental health is a crisis right now um, in this pandemic. And it's, again, a crisis that's not affecting everybody equally. Can you say a word or two about the mental health challenges and the inequality in that arena?
Yeah, no, absolutely. So I think, I'm thinking about mental health challenges also with healthcare workers, on the front lines, and this kind of being a chronic stress, but also obviously on Latinx communities. And we already know that there is a dearth of mental health resources for these communities. And so actually that's another place that we can think about really focusing, resources on, whether it be phone calls or, telehealth. We know we acknowledge the limitations of that, but it's just acknowledging that mental health and physical health are intertwined and really important for care.
Absolutely. So Dawn Gresham has asked, can you speak to the impact of police violence on mental and physical health of Black and Brown people?
Yeah, sure. I mean, there's a lot of really great data. Actually, there's a professor actually out in Minnesota, Rachel Hardman, who does a lot of this research, but really showing how police violence also not just affects detrimentally physical and emotional health, but it actually influences how Black communities perceive healthcare. And they found that in communities where there's more police violence, that there is a greater distrust of the healthcare system. And so people are less likely to seek care, resulting in worse health outcomes. And so that's such a great question. And just showing that all of this in so many ways it's interlinked, and that we can't. That's one reason why we can't just say we're going to try to fix healthcare, because we can't just fix healthcare without fixing the criminal justice system or without fixing education.
Absolutely. It is all tied together, as you so well explained. We have a question from Arturo Carvajal, who says, has a question about single payer or a public universal system that has been discussed for a very long time, and asking whether we believe that the coronavirus experience might indicate that this kind of single payer universal healthcare is the best solution.
Yes. You're talking to someone who wholeheartedly agrees with that, because one thing that we saw is tremendous job loss in this pandemic, and we know that tying health insurance to job status, that doesn't make any sense, because we basically are leaving people who are vulnerable even more vulnerable. And so I can't think of a better argument for universal health coverage, or even more specifically single payer, than this pandemic.
Right, because you don't lose your health care. You should not. This should not be a society where you lose your health care if you lose your job.
Exactly.
And now with 40 million Americans out of work, that has become more painfully obvious.
Yes.
And then there, as you've explained, there's healthcare inequality that emerges from lack of access to insurance.
Right.
Because people without health insurance are probably not going to get as much primary care or preventative care. And that is underlying the inequalities of this pandemic.
Right.
So that's an excellent question. Do you have any final thoughts for us, and as we near the 6 o'clock hour, Dr. Blackstock, on how should we be focusing our organizing energies in this very difficult period what we should be fighting for? How should we fight for it? What is your guidance at this difficult moment?
Yeah, no, so I think, this is in essence a call to action around structural racism. I think that we've seen just even over the last week how racism itself is it's a sickness, it's a disease, and it's left Black and Latinx, Native American. We didn't talk about Navajo Nation, but it's left with, which has like the highest per capita coronavirus cases. We haven't had a chance to talk about that, but profoundly sick, right? And so we really need to think about, all together, everyone, think about, structurally, how can we affect change so that we are not having these profound disparities, and that we can do it through how we vote, who we vote for. We can do it through advocacy. We can do it through who we donate our dollars to, what kind of organizations. We could do it through, our relationships with community-based organizations in our own areas. And so I think that there are many different ways that we can do this. And so, I hope that we use this really almost nightmarish moment for good and to improve the health and quality of life for Black, Latinx, Native American people in this country.
Thank you so much for that call to action. Thank you for this incredible hour, and thank you for what you're fighting for out there day to day in this arena. You are very active on Twitter, so could you tell us, if people want to follow you, how they can do that?
Oh yeah, you can follow me at Uché, UCHE _Blackstock, BLACKSTOCK. And can I just tell you that I wasn't really on Twitter much until like a year ago. And then I just started sharing all of my thoughts. And then apparently people thought they were interesting. So I'm glad to connect with people like you. Like you, Mark, because I think we're gonna be in the fight together, to address racial justice and the inequities in this moment.
We are, now more than ever. We have to stand strong in the face of the racism that is infecting so many institutions, whether law enforcement or healthcare or academia. And thank you for your guidance and your example. We're going to have to end it now, but I hope that you and your family stay safe.
Thank you. You too.
And I wish you all the best. Thank you so much, Dr. Blackstock.
Thank you.
And thanks to everyone who joined us.
Thank you. Thank you, everyone.
Stay safe, everybody.
For the questions. Okay.